All right. Well, thank you all so much for joining us for today's Doctors in webinar. And we have Dr. Jenny Moyer here, who's going to be our lead presenter today. I know many of you have been part of our Doctors in series before, either virtually or in person, but this is a partnership of the LGBT Elder Initiative at the William Way Community Center and the Jefferson Department of Family and Community Medicine and the Jefferson Center for Urban Health. So we've been doing these monthly Doctors in programs for about 2.5 years now and have covered a whole wide range of health issues and are grateful to all of the Jefferson geriatricians and doctors and palliative care fellows, geriatric fellows who have been part of this program. Before I turn it over to Dr. Moyer, just a couple of logistical things for the Zoom webinars. I'm going to make sure that the chat is enabled for everybody so that if you have questions as they come up, you will be able to ask your questions in the chat. There's also a Q&A feature, which should be at the bottom of your screen, a little Q&A button, and you can click on that to submit your questions to the presenters. And I'm just making sure that our chat is enabled here. Wonderful. So those will be the ways that you can ask your questions. Billy, who is on camera today, Billy is the Elder Initiative's new social work intern from Temple. And so she will be helping us today with the monitoring the Q&A and the chat. I'm going to pull up my screen. We had a couple little Zoom technical issues on my end. So I'm going to be showing the slides for Dr. Moyer. So I'm going to pull that up. And I'm going to turn it over to Dr. Moyer to take it away.
All right. Okay. So thank you everyone for having me in this virtual space that we've created for ourselves here. Like David said, I'm Jennifer Moore. I'm one of the geriatric fellows within the Department of Family and Community Medicine at Jefferson. I'm really happy to be here and to have this opportunity to talk with you all about this important topic. And I know Dr. Spina, one of my co-fellow, was speaking with you all last month. So hopefully there can be some interaction. I know it's on Zoom, but feel free to ask questions through the chat. And I'm happy to take questions throughout the presentation as things come up. All right, so we can move on to the next slide. So I just wanted to start the presentation by putting this question out there. How many of you have been affected by cancer? I think this is can be a really challenging topic for people to think about with either personal history, family, friends, loved one partners. And I think we certainly think about it as providers for patients as we are taking care of patients throughout their lives. And for me as a geriatric provider, thinking about it for my patients too. So just wanted to put it out there that I know that this can be a challenging topic and that hopefully this sort of allows you to feel a little bit empowered to talk to your providers about screening tests and to have these conversations with your loved ones. Next slide. So just brief outline of what we'll try to go over today. I'm going to go a little bit into the history of cancer, just some basic statistics, talking about who's at risk. The bulk of the presentation is going to be about the different screening recommendations that are out there. And then we'll touch on some additional resources or tips. Next slide. So what is cancer? Cancer, I'm sure many of you, all of you probably have heard of the term cancer, but what does it actually mean? And really at its basic form, it's that the cells in your body there are abnormal cells in your body that have started to multiply. And those abnormal cells have started to take over the normal function of your other cells. So this can really happen anywhere in your body, which is why there are so many different kinds of cancers. probably more than even I am aware of, and you think like, I didn't even know you could get cancer there, but it's something that can happen really anywhere. And it can look like many different things. It can look like a solid mass that you visually see on the outside of someone's body. It can be inside as a solid mass. It can be in the bloodstream. So it's really, the term cancer is very broad and can mean a lot, but it really just means that there's some abnormal cells that have started to multiply and are now starting to take over the function of your normal cells. So next slide. I was curious myself, so I was looking a little bit about the history of cancer, and really the first time that we know of it having been described is maybe about 4,500 years ago, when the Egyptians described it as masses on the breast. So at that time, they were seeing things on the outside of the body, and they would write about or document people having these masses that would come up onto the breast. Later, maybe closer to about 2,500 years ago, the term cancer started to come up, or the karkinos, meaning crab or crayfish, came up when Hippocrates started to describe several different kinds of cancers. And that the term cancer really came up because I guess when they were visualizing the cancer and they looked at all the blood vessels in the cancer, it just looked like they were kind of coming out in the form of a crab. And that's how that term came about. The word oncology comes from onkos, which means to just swellings or masses. And so we think about, in this world, cancer, oncology, oncologist, being the study of cancer in the medical field. So next slide. So why, I think, oh wait, there, yeah. When we think more about cancer in modern times, really, I think at least in the US, it wasn't until the 1900s and we really started to think about it on a population health level. And that's when the American Cancer Society was founded initially in 1913 under a different name. And then in 1945 changed its name to what it is now, which is the American Cancer Society. And really it was developed by a group of physicians who wanted to raise awareness about cancer, because previously it had been something that was not well studied, and it was sort of a physician to physician basis. So treatment, whatever they were offering, was very variable. The National Cancer Act was signed in 1971, and that really helped in terms of the funding, raising awareness among legislature, and putting laws into place to really promote cancer awareness. And that's when we started using this term, war on cancer. That helped to expand the National Cancer Institute, which does a lot of the research specifically around cancer screenings, treatments, and other things related to cancer. And it was partially because at that time, cancer had become the second leading cause of death. And that was one of the reasons that it seemed important for Nixon to sign this to sign the National Cancer Act. Next slide. And so why does cancer matter? Like I said, in the 1970s, cancer had become the second leading cause of death. And interestingly, it still is the second leading cause of death in the United States. So if we look at all the top 10 causes of death in the United States, heart disease is the first leading cause of death. And then we know that cancer is second. So like I had said, cancer is very broad. So it really talks about all different kinds of cancers. But it is the second leading cause of death. And so it's certainly something that we think about and talk to our patients about pretty often. Next slide. I wanted to put this up here. I know that this table or this picture divides this cancer that we think about into male and female, and it's very binary in that sense, but I thought at least this would sort of help to demonstrate that the top half demonstrates the most common forms of cancer, and then the bottom half goes into the most deadly or the highest risk of death related to cancer. So for example, for prostate cancer, although it is the most common, lung cancer does have a higher rate of mortality or a higher death rate associated with it. And so that is actually the #1 leading cause of death in terms of cancer is lung cancer, although that may not be the most common. So there are probably a lot of different statistics out there that you may hear about on the radio or at the doctor's office and may be confusing, but just to know that how much cancer is out there versus how deadly is it or what is the risk of death from cancer can vary depending on the types of cancer.
Jenny, we have a question.
Sure.
The question is, if I've had one cancer, how likely is it to get another?
That's a great question. So it really depends on the kind of cancer that it is. Certainly there are some genetic tendencies in cancers that there are some syndromes that we know certain cancers can be associated with one another, but that isn't necessarily always the case. So it's a little bit hard to predict exactly the risk of having another kind of cancer, but that would be something that the oncologist should, or your cancer doctor should be able to discuss with you. And it does not always mean that just because you have one, you're at a higher risk of having another type of cancer. And next slide. So we know that cancer happens. It's the 2nd leading cause of death in the United States. Is it preventable? There are some studies out there that say maybe even up to 40% of newly diagnosed cancers could be avoided in some circumstances. A lot of that, especially in the US, is related to smoking. So we know that actually the peak death from lung cancer has luckily already passed. So it reached its peak in 1991, and the death rate from lung cancer is going down, partially because people are quitting smoking more, and there's been a bigger campaign or a bigger push to cut back on tobacco use. But it is preventable in that way. And if we go to the next slide, I will just say that the best practices to reduce your cancer risk are probably a lot of the things that we already know out there as things that we should be doing. So not smoking or trying to quit smoking if you do smoke, maintaining a healthy diet, a healthy weight, increasing your physical activity, limiting your alcohol consumption, skin protection, vaccines, and specifically the HPV vaccine, which we'll kind of talk about later on. And then I would say knowing your genetic history, if you have access to that information, finding out, who in your family may have had certain types of cancers, what's your risk of having cancers, and talking to your providers about different screening tests. All right, so what is screening? So we know that it's the 2nd leading cause of death. We know that some of it's preventable. So what is the point of screening as well? So if we go to the next slide. So screening tests are tests and exams that can be done to detect cancers in patients who do not have any signs or symptoms of cancer. The goal is to detect cancer early before it has presented in any way, so that we can increase the likelihood that it would be more treatable. I think I think of patients that come in for their annual visit who are like healthy people coming in, they don't have any specific concerns, but when we talk about things that to try to prevent things from happening, and then we also talk about screening tests, that's who we talk to about screening tests. It's if people have symptoms, we no longer call it a screening test, and we will more likely call that like a diagnostic test or a different kind of test to actually look for something that's causing the symptom that may be there for the patient. Next slide, please. The main organization that we think about in the United States when we think about cancer screenings, or we get a lot of our recommendations, is from the United States Preventative Service Task Force, the USPSTF, which is a very long acronym, but it's a board that gets together. There are specialists on the board, they're community members, public health experts, epidemiologists, who really try to look at all of the evidence that exists out there for all things prevented. So this is not even just cancer, but it's a lot of other things as well. And they will make recommendations with certain strength associations, and we will go often by their guidelines when we talk to patients about regular screening tests. The Affordable Care Act, when it was signed, is designed in a way that all screenings that are endorsed by the USPSTF should be covered by your insurance. And we as providers, I go to this website routinely to look at the screenings that I should be thinking about for certain patient populations, different ages, different risk factors. Next slide. Screening in LGBTQ+ patients. Unfortunately, we know that there are lower rates of screening in patients who identify as LGBTQ+. Probably there are a lot of reasons that this is the case. Often it may be that research is done, often in cisgender people. Much of the current public health information is gendered. As you saw earlier, even the CDC publishes information that says female, male. And so it's really quite binary in terms of the research that's out there. So I think as I am going through this, to just try to think about what body parts do you have and what screening tests would be appropriate for you. And we'll talk specifically about some of the tests and differences for different people, but just to be aware that we know that this does disproportionately affect LGBTQ+ patients. And this this screenshot is from the National Cancer Network, which I'll provide the information for at the end, but it's a great website that has a lot of information specifically for non-cisgender people. Next slide, please. Just briefly, I wanted to talk about the risk of screening. Like, screening is great. We love screening patients, but there is always a risk when we talk about it. So the screening test itself, we'll go over different ones, but different tests themselves may have their own risk. And there is, in general, a risk of over-screening or over-diagnosis, meaning that we may find things that even though we found something, it would not necessarily change the course of someone's life. And kind of what do we do with that information? It can cause stress, it can cause anxiety. So something just to think about, that not all screening is good screening. All right, next slide. So now we'll kind of go into the bulk of this talk on cancer-specific screenings. Next.
Annie, before you go on, I have a question 2 slides back about alcohol consumption.
Yep.
Is there an amount of consumption that wouldn't increase a cancer risk?
So I would say that when we think about alcohol use, it's actually different for different types of cancers in terms of how closely associated the risk is with alcohol use and that cancer. But in general, there are certain numbers out there that are, again, sort of divided into like appropriate number for men versus women. And so I think in women, it's somewhere like 7 drinks a week. In men, it may be closer to 14 drinks a week. Or in women, they may qualify as more than 2 drinks per evening. In men, it may be more than 3 or 4 drinks per evening. So it's really, the hard numbers are a little bit harder to say. Like, if you drink more than 10 drinks a week, you are at increased risk of cancer. But just thinking about how much you are consuming in general and trying to reduce that amount if you feel like it is something that you notice that you are doing a lot of. So these are the specific cancers that we'll try to review, which is a lot of different cancers. But we'll go kind of in this order. And I just wanted to point out that the names of the things that we may be talking about are associated specifically with different cancers. So we'll try to move through these sort of in a rapid fire succession. So we'll start off with breast cancer. We can go to the next slide. So breast cancer, in the US, there are about 260,000 new diagnoses per year in the US. Overall, for people with breast, there's about a 13% lifetime risk. And when I say breast in this sense. It's more classically what we think of as females. So a lot of times in literature, we'll say there's a 13% lifetime risk for females. The guidelines for screening do vary a little bit. I had mentioned the USPSTF, or the United States Preventative Services Task Force. Then there's the American Cancer Society, and sometimes their recommendations aren't always in line with one another, so they may differ a little bit. But generally, there's some sort of recommendation between the ages of 40 and 74, and the frequency does depend on the organization that we look at too. So if we go to the next slide, the screening test that we typically think of for breast cancer is called a mammogram. It's an X-ray of the breast that's done in an imaging center as an outpatient. It can be uncomfortable, so there's the drawing of what happens below in their picture, but you are generally standing up. They take your breast and they will put it in between two slides and try to image it in different angles to try to visualize the entire breast. They can generally take additional images if needed right then and there if they see something, but that then gets read by a radiologist, and that report comes back to the physician or to the patient themselves. So this at Jefferson is done at the breast cancer imaging center, and a lot of different institutions within Philadelphia probably have their own breast imaging center or some place that specifically does breast cancers, mammograms, sort of all things related to breast cancers. Next slide. So I had mentioned the age range being somewhere between 40 and 74 or so. So the guidelines are pretty concrete for the ages 50 to 75 or 74, that mammograms are beneficial and are recommended for that age. Between the ages of 40 to 50, there's a little bit more different people will say there's not enough evidence to demonstrate a benefit for patients. So this tries to go into that a little bit. So if we know that 25 women will die from breast cancer without screening, if we screen women between the age of 50 and 74 every 2 years, so that means getting a mammogram every other year, we can reduce that number 25 to about 18. So we can say maybe we will have 7 people avoid death from breast cancer. If we instead started screening at age 40, we could potentially avoid an additional 1 death from breast cancer. So that number would be from 18 to 17. And that's kind of where you have the conversation with your provider about the risks and benefits of screening. Some people will say that it's thinking about screening, knowing that there's a lower likelihood of having cancers, or maybe no one in their family has had breast cancers, or they don't feel other things that they would like to prioritize may not be worth screening at between the age of 40 and 50. And that is a decision to make with your own provider. Next slide, please. So this is specifically screening for transgender women. This is from a report that was published by Fenway Health in Boston. It's a great resource that has a lot of information out there for the LGBTQ patient population. But for transgender women, the question that we think about is, have you been taking feminizing hormones for 5 years or longer? If the answer is yes, then an annual mammogram, or this says annual because the recommendations are somewhere between annually or every other year, but most likely starting mammograms at the age of 50 are going to be beneficial. If you have a family history of breast cancer, then you would want to discuss this earlier with your provider because there may be some benefit to screening a little bit earlier. Next slide. If you are a transgender man, the question is if you've had chest reconstructive surgery. So if you've had chest reconstructive surgery, then there is a recommendation for you to potentially be getting annual chest wall exams. And this may be done at your surgeon's office, because I know patients will often be followed sort of annually by their surgeons, to just examine the area where you did have the surgery and to take a look at the tissue that's there. If you've had a breast reduction surgery, which typically means that there's more breast tissue that may be left there, you could still consider a mammogram starting at the age of 50. Again, we don't have a lot of research specifically for this this group of people, and so it's probably something that is worth discussing with your provider as well. And then if you have not had any surgery at all, and you do still have your breasts, then it is recommended that you would follow the routine screening guidelines from the USPSTF. Next slide. Other things to think about for cisgender women. Generally, if you are maybe at increased risk, if you have not had a pregnancy or you have no breastfeeding time in your life, or with higher rates of obesity, higher rates of alcohol use, higher rates of tobacco use do increase your risk of breast cancer. So just to be aware of those things overall for breast cancer. So the overall summary for breast cancer is probably should be getting mammograms either every year or every other year between the age of 50 and 74, and then between 40 and 50 to have a conversation with your provider. All right, next slide. So moving on to prostate cancer. So prostate cancer, about 192,000 new cases diagnosed per year in the US. Generally, there's about a 12% lifetime risk for developing prostate cancer if you have a prostate. So screening for prostate cancer, even in the medical community, there's been times when we're very enthusiastic about it, times when we weren't, and it kind of comes back and forth. The test that we have right now is a blood test called a prostate-specific antigen, or a PSA test. It's a blood test, so it would be something that's just done in by a phlebotomist in a lab. They may be able to do it in your doctor's office themselves. Excuse me, but the USPSTF says that you could consider using a prostate-specific antigen, or a PSA, to screen for prostate cancer. The American Cancer Society also mentions really that you should just talk to your doctor about it. The American Urologic Association says specifically it should probably not be done for people over the age of 70, and then between the ages of 55 to 69 to talk about it with your provider. The reason that this testing is really, no one is really saying like, yes, you should get this done, is if you go on to the next slide, the PSA testing in general, we are finding that potentially the test results are kind of inaccurate or unclear exactly what to do with them. So we think about there being a normal level and then an abnormal level, and we're not really sure what the threshold should be. And previous studies have found that there is a high risk of overdiagnosis and overtreatment for generally a slow-growing cancer. So we're not really sure, even if we do screen people, does it prolong your life? It's a little bit harder to say, and different studies will say different things. And if we go to the next slide, this is kind of another picture that will help us look through this. So if we have 1,000 people that are offered the PSA screening, about 240 people will have a positive result. That might indicate prostate cancer. There are a lot of other things, such as just having an enlarged prostate, that can make this number high. And so that's one of the things that we have to tease out. And the way we would do that is potentially by getting a biopsy, which is a procedure in and of itself that has its own risks. So of the 240 people that have a positive result, 100 of those people would get a positive biopsy, and 80 of those people may choose surgery or radiation treatment to treat this cancer. But even if we treated those people, we probably only are going to avoid about 1 death from prostate cancer, even though we screened 1,000 people. And so that people kind of have to interpret that for themselves. If you feel like I'm not going to be that 1 in 1,000 and it's not worth it to me, then you certainly don't have to get the test. If you are more on the spectrum of feeling like I really want to know and I would get treatment because I don't want to be that 1 in 1,000, then that would be a reason to consider getting this testing done. All right, moving on to lung cancer. So as I had said, lung cancer, there are high rates of it, but it is overall declining. Though in the US currently, there are about 230,000 new cases per year. The screening for lung cancer can be done with a low dose CAT scan, and it's actually only offered to those with a history of tobacco use, because we know there's such a high correlation with tobacco use and lung cancer. So on the next slide, we hear the specific lung cancer screening guidelines. So for those between the ages of 55 and 80, you have no symptoms, again, because it's a screening test. You have to either currently be smoking or quit within the last 15 years and have at least a 30-pack year history. That means that either you have smoked 1 pack a day for 30 years, or it could be half a pack a day for 60 years, whatever that number is to get to 30 packs per pack year history. Those are the people that we would recommend a CT scan being done annually. And this is a CAT scan that's done, so it's done again in an imaging center. It's a type of imaging study. And the data that we have for it is, we certainly are doing it, but again, I think people maybe think it might be more effective than it is. So out of 1,000 people who are not screened for cancer, lung cancer, with the screening test, about 21 people may potentially die from lung cancer. If we screen those 1,000 people because they fall into this category that meets the screening guidelines, we think that maybe about 3 lung cancer deaths could be avoided or prevented, and that's with annual screenings for 3 years in a row. So again, a little bit hard to say exactly, but this is a recommendation and it is offered as something that for those who are at higher risk because they do smoke, we can order for patients. The next slide, a lot of patients will ask me, well, how much radiation is a CAT scan? It seems like a little bit more than just an X-ray, but this shows you a little bit what it would mean for you. So a mammogram is a little bit less than this low-dose CT scan for lung cancer screening, which is still less than the average background radiation that we think people may be exposed to just by living in the United States. And it is quite a significant amount less than a diagnostic CAT scan, which may be a CAT scan that you would get if you had symptoms and we were actually looking for a very specific thing. All right, so colorectal cancer, I know has been on the news recently with death of a famous actor, but in the US, about 148,000 of new cases diagnosed per year. Overall, the rates seem to be declining for patients, though there is some concern that the rates may be rising for those between 40 and 50 years old. Colon cancer screening can be done in several different ways. So we think about a colonoscopy, which was sort of the traditional way, or a sigmoidoscopy, a FIT test or Cologuard test, or CT colonography. And the next slide, we talk about when and how or who gets this colorectal cancer screening. So the guidelines are also potentially changing, but the USPSTF says that they do recommend cancer screening for average risk people at the age of 50. because of recent information that has been coming out that potentially there's an increased risk between 40 and 50, the American Cancer Society, actually, if you go onto their website, will say to start screening at age 45 now. And the USPSTF is actually currently looking at the colon cancer screening guidelines, but they may potentially adjust it to 45, maybe specifically for African American patients, but potentially for all patients. There are several different testing options. And if we go to the next slide, the two different kinds of tests, there's a stool-based test and the visual test. The stool-based test is generally done at home. The picture on the bottom right is Cologuard, which I feel like there are so many commercials for out there right now. But it's there, even with the stool-based test, there are several different types of tests. There's a FIT test, which is done every year. The Cologuard itself is done every 3 years. So the frequency depends on the kind of test that's ordered specifically for you. So that's a test you would do at home. You have a bowel movement in your own toilet, you collect a little sample and you send it to the lab. And you would either get a positive or a negative. If it's negative, you would need to repeat that test based on the frequency of the test requirements. If it's positive, you would have to get a direct visualization. So the visual test is a colonoscopy, is the gold standard. It's every 10 years. This test is a test where either a gastroenterologist or a colorectal surgeon would go and actually visualize the rectum and the colon. So they take a camera and they insert it into your rectum or your anus, and they look at your large colon to see if they see anything that looks abnormal, any bleeding, any polyps. If everything looks normal inside the colon, then you repeat it in 10 years. The CT colonography is a CT scan that's actually not used as often. And the flexible sigmoidoscopy is a similar visualization as the colonography. It just doesn't go as high up as the colonoscopy, and that's recommended every 5 years. So even though all these test options are out there, probably most commonly you will hear about the colonoscopy or a FIT test or a stool-based test at home. All right, next. I threw a slide in there about skin cancer because I think people think about it often. And in terms of prevalence, it sort of falls next in the order that we're going. So about 76,000 new diagnoses of melanoma per year. There's a lot of different types of skin cancers, but this is the one that has a higher risk of mortality. So basal cell carcinoma, squamous cell carcinoma, those, even though that accounts for like 98% of skin cancers, they are also really localized and very, very rarely lead to death, whereas melanoma can be more advanced. Unfortunately, there's no really great screening test for melanoma. Or for skin cancers in general. Even if you look at the USPSTF, American Cancer Society, there's no great information about how often you should get any sort of screening test. There's no blood test that can be done. The general recommendation is kind of just to know your skin and know if you have certain moles in certain places. And we would be looking for changes in your moles over time or rapid changes to the size, color, if they're changing in texture, if they're becoming painful. Those would be reasons to alert your provider. But really, there's like no specific hard evidence for screening for melanoma skin cancers. Moving right along to cervical cancer, about 14,000 new diagnoses per year in the US. So a lot less than breast cancers, prostate cancers, which are closer to 200,000. The screening right now is done with a speculum and a cervical brush or a wand. There is some research out there about potential for a self-swab, but that's sort of something that we're working on figuring out as a medical community for now. Next slide. For the recommendations in terms of the screening guidelines, so for those with a cervix, we recommend starting screening at the age of 21. At 21, you would get a pap smear test, and generally the way it's done is we have a speculum that we would insert into your vagina or your frontal opening, and we would try to actually visualize the cervix itself, and we would take a sample of the cells on the outside of your cervix and send it to the lab. They would look at that and actually look at the cells to see, is there anything that looks abnormal with the cells? If all the cells look normal, then you would be due for a pap test every 3 years. Once you turn 30 years old, you can space it out a little bit because we can add on a test for HPV, which is the human papillomavirus. This co-testing can be done every 5 years. So if you get the test, which is done the same way with a speculum and a swab on your cervix, and everything is negative, then you can repeat it every 5 years. Right now, there is, you can also do just a HPV test, but we are still doing it as a provider or someone inserting a speculum and visualizing the cervix and getting a swab, as opposed to a self-swab, which patients may be doing now for STD testing. We don't have great data on whether or not that's sufficient for the purpose of screening for cervical cancer. For those with HIV, screening starts at a different time. So this would not be for patients who have congenital HIV or HIV from birth, but this is for people who have acquired HIV. Generally, the recommendation is to start at the time of HIV diagnosis. And then to screen every year for 3 years, and if normal, to extend the duration of frequency to every 3 years. At age 30, we would start co-testing, so doing the pap smear test plus looking for the HPV virus. But even at that point, we would still do it every 3 years. All right, next slide. So the last cancer I'm going to be talking about is anal cancer. The prevalence of this is a lot less. So only in the US, there's only about 1,000 new diagnoses per year, though the incidence is likely rising. So if we think about all the different cancers we've talked about, even lung cancer being 230,000 per year, breast cancer, prostate cancer being right up at that number, anal cancer is a lot less, it's about 1,000 per year. We know that it's highly associated with the human papillomavirus, which is the same virus that we have associated with cervical cancer and some ear, nose, and throat cancers as well. And the test that we could potentially do is an anal pap smear or high resolution anoscopy test. The anal pap is similar to the cervical pap smear in the sense that we would get a swab of the cells and look at them under the microscope. And an anoscopy test is using an anoscope that we would insert into the anus to actually look at the tissue of the anus and see if we see any changes that we think might be related to HPV. Next slide. Because the rates of anal cancer are very low compared to other cancers in the US, there aren't very clear guidelines on who should be getting testing. The USPSTF does not really have any guidelines. And if you look at the American Cancer Society, it's not so much guidelines as it is an expert recommendation, meaning specific individual physicians who have had experience working with patients who may be higher risk. And they may recommend for men who have sex with men and are HIV positive to screen annually with an anal pap smear. For men who have sex with men and are HIV negative, maybe doing every 2 to 3 years. Women who have a history of cervical cancer or vulvar cancer, to potentially think about doing it. Again, we don't have a lot of great evidence for this. And I was actually talking to one of the family medicine doctors who takes care of HIV positive patients as a primary care provider, and asking him what he generally does. And he said he actually doesn't necessarily routinely do it because it's even clear what you do with that information. So I think this is something that we are still learning about as a medical community. Certainly if you have any symptoms of anal cancer, which would then sort of no longer be screening, but would be more diagnostic, that's different. But talking to your providers about whether or not would be worth doing an anal pap smear if you believe that you fall into this higher risk category. So if we go to the next slide, we talked a lot about different cancers, a lot about different screening tests. I'm not sure if people had questions or if they've come up along the way, but I certainly wanted to touch base on just when to stop screening. So the next slide. So I think about this a lot for my patients that are older. If you noticed, a lot of the recommendations go maybe until age 74, 75, 60, depending on the cancer itself. So we know that as you get older, different screening tests can potentially cause more harm. Some of it may be because the screening test itself, for example, a colonoscopy is a procedure where you do have to get sedation, and it is a procedure that has its own risks like bleeding, infection, and that in and of itself can be risky, but also because the tests can cause some unnecessary anxiety, stress, add more tests in addition to just the screening test itself that may not necessarily change the course of someone's life. Dr. Salzman and I were actually seeing a patient this morning who I think is in her late 90s, maybe 97, I can't remember, Dr. Salzman, who had at one point in her 80s had this conversation about, should I get a mammogram, should I not? And she had gotten a mammogram. And it actually did show something, but after she got the mammogram, she said, I actually don't want to treat it. I don't feel like it's not bothering me. And then eventually, as the cancer took its course, she started having some symptoms and some pain, and that's when she opted to treat it. So the fact that we got the mammogram for her didn't really change anything because she wouldn't have acted upon it unless she had symptoms. And so I think the question really that we think about is generally how fit or how overall healthy are you? And if you found out you had cancer through a screening test, would you want to pursue treatment? Would it be worth it to you? Or would you prioritize other things in your life at that time? And that's when we would say, maybe it's time to stop screening tests or going to look for these things if you wouldn't necessarily act upon this information. Lastly, just to give you some websites that I certainly use to help me with this talk. I mentioned Fenway Health is a great organization up in Boston that has a lot of published reports. A lot of the research comes out of Fenway Health, specifically regarding screening for cervical cancer for patients with HIV, or mammograms for different people who have different hormones that they're taking, people who have had surgeries. The Cancer Network also is a great resource for patients, American Cancer Society, and then the United States Preventative Service Task Force. I did put a picture of the Mazzoni Center up. I know that they're an LGBTQ-friendly health center that also talks to patients often about this. So certainly those providers would be comfortable to address some of these questions that you may have. And then just to kind of sum it all up, since this is a lot of information, David has the slides, and so I'm happy to have people have access to this information. But I just wanted to say, what's the take-home point? So cancer is the second leading cause of death in the United States. And we know that we can try to reduce the number of patients who are diagnosed with cancer by screening. Screening is for patients without symptoms. So at the point where you have any symptoms, then it no longer is screening. Generally, think about what body parts you have. If you have a cervix, if you have a prostate, think about getting those certain parts screened for the cancer that's appropriate. And then find a provider that you feel comfortable with asking questions to and having conversations with. I think a lot of these are personal decisions. Even the guidelines that I have or that we have as a medical community, there's some wiggle room in terms of the age that we start, when we stop, how we talk to patients about it. So find a doctor that you feel comfortable with to talk about these decisions with. And then know your body. Overall, the best things you can do are probably the things that your parents have told you, everything everyone else has told you: eating healthy, trying to maintain a healthy weight, healthy diet, getting some physical activity, cutting out some of the things like smoking and limiting alcohol consumption overall. And so that's kind of what I have for you all. You know, that's a lot of information, but if anyone has questions, I'm happy to answer them. Dr. Salzman is here as well, and she certainly has had more experience than me in screening. So
we do have a question. So this is from Steve. It says, I have CLL. My blood work is monitored by my oncologist. Can you explain what blood-borne means? Is there something floating around in my blood?
So yeah, that's a great question. So CLL is a type of cancer that is not a tumor that we think of as something that grows on the outside of your body, but it's within your bloodstream. And so that's why they call it a blood-borne cancer. Not necessarily that, I guess the best way to describe it is that the way that our bodies generate blood cells, sometimes the genes that go into that can be affected. And so for patients who have blood-borne cancers like leukemia or which is ALL, or chronic leukemia CLL, the genes that go into making your blood cells, which are done regularly as we are sitting here, our body's trying to make new red blood cells, those have started to change, and that mechanism is abnormal. And so that's why we think that's probably why your oncologist is using the term blood-borne.
Were there any other questions that folks want to get in to Dr. Moyer before we break here? You can put them either in the chat or the Q&A box. One thing I wanted to ask, just as a clarification. So in most of these, it sounds like these are screenings that folks can have done by their primary care doctor. And so that's sort of the one point of entry for folks who talked about all these screenings with.
Yes, so your primary care doctor should be able to talk about these with you. And I know that certainly Brooke or Dr. Salzman and I think about these every time our patients come into the office. We're checking, you know, are you up to date on your mammogram or your colonoscopy? So the primary care doctor is a good starting point for that. I think certain people that may be at higher risk for different kinds of cancers, we may refer to, for example, for anal cancer, if I believe that there is a higher risk, I will probably refer you to potentially a colorectal surgeon or a gastroenterologist who may have more specific information regarding that. But a primary care doctor is a great place to start.
Great.
And I think this is a great community that you all have. If you have providers that you feel comfortable with talking about these things with, whether it's people within Mazzoni at other institutions, I think finding a doctor that you feel comfortable with is so important, a primary care doctor. And so sharing that information with your friends, your loved ones, your partners is going to be great.
Wonderful. Well, thank you so much, Dr. Moyer. This was a lot of information, but really important stuff.
Yeah.
Thank you for walking us through it all.